This is Nassim Miller reporting from the 2012 Cardiovascular Research Technologies meeting, where I spoke with the program chair, Dr. Ron Waksman. Could you talk about some of the game changers in this year's meeting that are discussed?
Well, I think now we do have TAVR approved in the US, so obviously it's add another dimension to what the interventionalists can do in the cath lab. We have approval and access to a limited number of patients with percutaneous aortic valve replacement, so that's definitely a big change. I think there are other issues which is related more to the appropriate criteria of which patient should be done, at what situation, how should they be done. So I think these are really very important in terms of the landscape of interventional cardiology. And the third thing is we get more information about the second generation drug-eluting stents, about their safety features, and I think that also helps a lot in terms of getting comfort with levels of stent thrombosis and understanding the performance of those stents in our patients.
In the coming year, what issues do you think interventional cardiologists should pay attention to?
I think they should pay attention, first of all, to the appropriate criteria. If in the past we used to treat every stenotic segment, now we have to be more cautious about whether these are really generating ischemia. It's not anymore the ocular restenotic reflex. It's more related to demonstrated there is ischemia, demonstrated there is, by intervening, it's going to really help to the patients, whether it's going to alleviate his angina, reduce the ischemia, and potentially also would extend the life.
One of the magic words this year is heart teams. How do you think that's going to change practice?
It's already there. What we're seeing more and more, that there is an integration between interventional cardiologists group to surgeon groups. We work as a one group and a cohesive. Patients are discussed not only for TAVR, they're also discussed for multivessel revascularization. So we see that there is going together as a team, and it's probably beyond that when it comes to TAVR. There is also anesthesiologist, echocardiographer. The whole team is actually evaluating the patients, so it's not anymore a one-man shot, it's a team approach. And I think this is not a lip stack, this is for true, I mean for real, that there is an entire team that's involved in the patient care, and I think it's a win-win situation for the patients and for the rest of the medical community.
And to wrap this up, can you tell me where do you hope to be next year, and what are some of the issues you hope to have resolved or be talking about next year when you come to the annual meeting?
I think we still have to get some clarification about the appropriateness criteria. We would like to see, and I think there will be a breakthrough this year in the ability to do more first-in-human trials in the US. We'd like to facilitate facilitate approval of devices, so to shorten the gap between approval OUS into the US. And I think we should stay tuned to more development in the valve arena. There is new devices, there is improved generation of those devices, and there may be also expansion of labeling for other accesses. There is anticipation that there will be a panel in 2012 in terms of expansion of the use of TAVR for a high risk, not just the inoperable risk. And finally, I would say that from the technology-wise, we are going to see better technology. So remember, now we're dealing with first generation, we're looking for the second generation. So I'm hopeful that, I'm actually certain that next year we'll be able to see further development in this device development and opportunities, and discuss good studies that we can implement for future years.